Okay, so now we're going to transition over to the arrhythmias. So again, you're in the EKG Winter Wonderland, and I have not had a chance to introduce myself yet to a lot of you who I may be newly meeting. And my name is Jen Carlquist. I am your hostess today, and also a cardiology and emergency room PA of, we're in the neighborhood of 16 or 17 years now. Prior to that, I was a paramedic for 13 years. And so we put this together because we love to teach. And we love to give back to our community. And this is also going to set you up as a springboard, hopefully. If you do want to join the 30-day EKG challenge, this is going to give you some basics and fundamentals to know that you are in the right place. So let's kick it off. And I want to see my fast typers with giving me our answers for our arrhythmias. And let's dive into it. So here we go. So 3 questions that I always ask myself when it's time to interpret a rhythm. And this will help you no matter where you are or what you're doing in any walk of life, EMS or otherwise, right? So the first question you're going to ask yourself, is the rhythm, is it narrow or wide? Okay, is the QRS narrow or wide? If it's narrow, we know it's coming from above the ventricles. If it's wide, it's coming from below. Okay, that's the big clue. The next thing is it fast or slow? So if it's really fast, do we need to stop and do something right now? Or really slow where it needs to be addressed? Because if not, we can proceed on and figure out the rhythm. And then regularity is where you take and you go from the R to R. And when you're looking at that, you're looking at from here to here, what is the distance? Is it the same distance? And if so, you're most likely dealing with a regular rhythm. So things that are regular, things like sinus, things like SVT, those are regular. So let's dive into things that come from the atrium. And here's the list of all the things that you can have, our little menu. But I wanted to see who knows what this rhythm is here. Who knows what this rhythm is here? It is irregularly irregular. That's a clue. And the question you ask yourself is there any distinct P waves? And it looks like a lot of you are already saying AFib. Hey, come on, what's up? I saw you join. Hello, hello. Yes, Tanya, this is AFib. And we know that because there's no discernible P waves. And that's the clue. It's irregularly irregular. Good. Okay, so it looks like we have everybody answering on that. Strong work. Now, here's another one for you. This is the questions you ask yourself. Is it fast or slow? So you can look at this, you could calculate it out, but you can see it's not too slow where we need to send the patient to the ER. It's definitely not fast. And if you look at the R to R, it is regular. You can see, yeah, it is regular. It's the same distance. And is there a P wave? Yes. Is it the same shape? Yes, which is also called morphology, if you've heard that term before. And this is kind of what we most likely hope to see on the monitor. Look at you guys already guessing. And this is none other than normal sinus. So good job. Now here's another rhythm we're going to practice on. And this one could be confusing. Yes, it was a little bit, Brady. This one is a little confusing because it is irregular. There's more distance from the R to R if you were to march this out. But when you see this, what you do is you really ask yourself, is there P waves? So Hillary, good question, good thought. I'm going to come back to that. But a lot of folks are saying, no, this is not AFib. And TC, you actually got it right. This is a sinus arrhythmia. Same with you, Tanya. Good job. And so, Komal, good job. So yeah, the question is it AFib? And it's not. And here's how we know, because we do have discrete P waves. They are there. You can definitely see them. And the question was that somebody asked, which was a good question, is there pauses? Okay, is this a sinus pause? That's actually a very high level question and thought there, because, it could be, right? It could be a pause, but what you would need to know is a longer strip to really say for sure, because a pause would just come and every other R to R would be regular. But when you have the varying R to R, that's more consistent with sinus arrhythmia. And the answer, good job, who said it on here, Silas and KJ, the answer is breathing. Okay, so this isn't AFib, it isn't dangerous. You don't need to do anything. And as Allison said, respiratory variation. Now, bradycardia, okay, is something slow, under 60, still have P waves, right? You know the sinus is running it when you see P waves, and you always want the sinus node to be in charge. So I had an instructor in school who used to say, sinus makes P. And it seems weird that that would be the thing that stuck in my brain, however many years later this is, but it did. And you can see that the R to R is regular, and you have distinct Ps. So it's a little bit slower than we would expect. So this is indeed a sinus brady, and it is regular. So really quick question for you. Is there anything you could do as a provider to cause this? So I see Silas and Diksha saying already that athletic can cause this, and that's true. Athletes can have bradycardia, and it's their normal resting rate. As Allison said, you could be over medicated with a beta blocker, but ultimately you're going to look at their med list, and you're going to also ask them if they're symptomatic. So those are the big questions. And calcium channel blockers, beta blockers can cause bradycardia as well as antiarrhythmics. So let's do this one. This is a fun one. What rhythm is this? What do you guys think? Sinus brady. Can sinus brady be much lower than 40? It can. Yep. Atrial flutter. Amy, good job. This is, I'm sorry, no, not this one. I'm thinking of the next one. This isn't a flutter. It looks like it is, but yes, Alyssa, this is sinus tach. Ilijana, you're here. And also Diksha, this is sinus tach. So what are some things we can do to cause sinus tach, or what can a patient come in with that could cause sinus tach? Anxiety, good. What else what can you see in like their labs? So infection, anemia, beautiful. Drugs, fever, dehydration, excellent. These are all great. Okay, so we're always thinking about the cause. COVID can cause it. So can anxiety, toxicities, right? These are all good. So find the cause and treat the cause, not the rhythm. Now, this is the one I was going to present next for you. What is the rhythm here? I love that you said PE, Allison, by the way. KJ, figure out your why. Yes, this one is a flutter. So how do we know that this is atrial flutter? And Michelle says all the energy drinks. And yes, Tanya, TSH, I agree. This is flutter. Yes, been duped on that before. So it's got a sawtooth pattern. Absolutely, you guys are spot on. Look over here. You've got the sawtooth. It looks like a fence, a picket fence. And these are not P waves. These are called F waves, also known as flutter. So the question I would have for you about this is, can flutter actually, oh, shark teeth. I like that you said that, TC. Can flutter cause stroke? Is it possible? Yeah, absolutely. A lot of people don't know that. So you do have to be careful. You do have to do a CHAS-2 score on someone with atrial flutter. And if it's elevated, they potentially need anticoagulation to prevent stroke. Now, this is obviously something we saw before. This is our AFib, but I wanted to make sure you understood something. Patients with AFib can complain of a lot of different things. What have you heard patients complain of when they're in AFib? Can you give me some examples? Slow AFib is no bueno. I like that. Can you give me some examples of things patients have told you? Feels like wiggling jello. It's a good one. Palpitations, fatigue, short of breath, dyspnea, chest pain. These are all great. Palpitations. Has anybody ever heard, I feel like there's bubbles in my chest, or I feel like there's butterflies? Anything like that? I feel like patients, butterflies, I feel like they read the manual before they have their issue. They're like chest pain. Oh, elephant sitting on my chest, because everybody knows that one. And then everybody has these great descriptions of AFib. So the key is that AFibers can even come in, believe it or not, kind of a little bit altered or confused. So yes, they could be throwing little strokes as well, but because you lose your atrial kick in AFib, it's a good idea to make sure you get the EKG. So any complaint like that, priority to complaint, any of you have listed here, or other things like the fatigue, always have a low threshold to get an EKG. Okay, there's only one rhythm that we really have to worry about in the junction on a day-to-day basis, and that is the junctional rhythm. Now, you can have something called an accelerated junctional. You most likely will be seeing that after they have a cardiac arrest and you've given them some epi, right? But it's not a usual thing to see an accelerated. In fact, I think I've seen it maybe twice in my, well, maybe 3 times in my all of medicine. It's very, very rare. If you've ever seen an accelerated junctional, type in the chat. I would love to know. But the key is, do you have a P wave or not? And in the junction, you know the sinus is not running it, so you don't have a P wave. But it's still a good rate, usually 40 to 60, and it's a narrow complex. So that way you know it's coming from the above ventricles. So the AV node is in charge. So Allison has seen it post-arrest in the ICU. Hooking up words, phrases, and clauses. I'm not sure what that means, Silas, but you're always like the biggest comedian in here, so it's probably something funny that I'm missing. So the junction is really in charge. But if you have a junctional rhythm, right, it's not something that you need to freak out about right away. You have time to figure out what's going on and, figure out why are they not using their P wave anymore? Are they symptomatic? And then ventricular things, there is a couple things we want to go over. Idioventricular, oh, Schoolhouse Rock. That's right, that is my generation too. So idioventricular rhythm. This is something that is wide. Wide, we know, comes from the ventricles. We also know that it is slow. Wide, slow, regular is idioventricular. And this one is probably not going to have a pulse, okay? So other people can call this a PEA. That is also technically correct if they have no pulse. You will oftentimes see this as somebody is, dying, in the active phases of dying. Hopefully you never see this in your clinic. That would be bad. A lot of EMS folks will see this, but in their average day. But again, it's knowing that there's a regular pattern, it's wide, and there's no P waves. Then getting into the agonal rhythm, this is something, again, that EMS will deal with a lot. Teletext too, yeah, good one, TC. Are there any teletechs in here? I know, Teresa, I think you're a teletech. Is there any of the teletechs that are here with us? We'd love to hear from you. So agonal, you've got basically 0 to 20 beats per minute. And the QRS is going to be wide and bizarre. And that's basically when one little lonely heart cell at the very bottom is trying to run the heart and it's not doing a very good job. That's right, Tanya, you are too. That's right. And so agonal, again, is going to have no pulse, and the heart is tired. Exactly. So you often will see this as the very last thing before they go into cardiac arrest. Exactly, they're tired. So in a nutshell, I'm going to stop here and I'm going to get up my other screen to share with you some live rhythms. What is your favorite rhythm? What is the favorite rhythm that you guys have? Would love to know. So let's go over here. Let me make sure I can see the right. VTAC's your favorite. Okay, let me see if I can see the right screen. And then if I can, I'm going to pull up some live rhythms for you. Looks like we can. All right, guys, this is actually from our good friend Gary Krause. He's an RN as well, who teaches in our 3-day and our 30-day. And this is from his workbook. And I'm going to go ahead and show you a couple of these strips, and I'm going to see if you can guess which ones we are dealing with. So I'm going to go ahead and play. And I want you guys to type in as soon as you see it and know it. Oh, actually, okay, so what do we think about this one? Let's see if there's any chats. Okay, we have a lot of normal sinus votes. You can see the heart rate is 62. That would be corresponding with the normal sinus. Let's see if we're right. Can't trick you guys, huh? PR is normal under 120. QRS, significant Q waves there. And that's the key, is more than 0.3 seconds wide. Okay, so that one, a Q wave, a lot of times caused by infarct, right? But sometimes Q waves can mean other things, actually, like pulmonary embolus or hypertrophic obstructive cardiomyopathy. So Q waves don't always mean myocardial infarction, but good job on everybody who said sinus. I wasn't trying to fool you, I promise. So let's do this one. This is strip 24. Okay, this one's kind of hard. So this one is wide, it is regular, and it is fast. So it's a heart rate of 150. What do you guys think is going on here? And it's totally okay to say you want a 12 lead. That's always a good answer. Everybody's voting SVT mostly. Okay, let's see. I like that you guys thought about VT because we always want to think wide is VT, right? There we go. Awesome job, you guys. So let's do another one. Let's just do a random one. Let's do 47 and type in your guess as soon as you know. Okay, any guesses? Let's see what we have in our guess box. We have a torsades. We have lots of torsades. Okay, let's see if you're right. I think you're onto something here. Get mag. Nice. So good job on everybody who chimed in. That was torsades. How long is too long for the QT? Does anybody have any numbers for how long is too long? Yes. So it's actually 450 in men and it's 460 for women. So anything over those two, strong work, everybody, put that in the chat. Okay. So generally, if you remember 460, you're going to be safe. And Amy, 500 is bad. That's when you usually see the torsades. And that would be definitely something to be concerned about. So does anybody want to type in a guess of can you type in a couple medicines that you can think of that could prolong the QT? Yeah, I know, 500. Yep, amio can prolong it. SSRI, Ticacin, Sotalol, these are all good. Zithromax, these are wonderful. So there you can see there's a lot of things, a lot of the psych meds. Zofran is for sure. So we always have to be really careful and Haldol, yes, but to be very careful about the medications we choose. And so knowing your QT is always important. All right, here we go. Yes, Mackenzie. Let's do another one. Oh, yeah. Okay, so what are your thoughts on this one? Is it regular, irregular? Okay, good. Yeah, it's definitely wide. There's no P waves. It is regular. Good. Okay, let's see what we come up with here. Mm. Yeah, this one was kind of a rough one. Let's choose a different one. Let's choose 71. Here we go. Oh yeah, this is easy, right? You can see those pacer spikes. You guys are all seeing it. Yep, measuring out all out. So there's basically both atrial and ventricular pacing. That's why you're getting the two spikes, and that's what's making the QRS wide. So that's pretty easy. I also wanted to mention that this badge that I'm showing on the screen is something you're going to get if you join our 30-day EKG challenge. So if any of you are seeing this and like, oh, I really want one, and you're not going to join our 30-day, you can buy them. They're online. They're in Amazon, called the RCAT badge. But if you are joining, don't buy one because you're going to get one and one of Matt's badges as well. So don't grab those if you're planning on joining our 30-day EKG challenge. We're going to do one more strip here. So let's make this one. Let's finish strong. Type in your answers when you see it. And here we go. Ooh. Got a couple things going on here. Let's see in our chat what you guys think. Okay, yeah, thank you for putting that, KJ. So pericardial, oh, I see why you're saying that. Kamal said pericardial effusion because there's a small beat, big beat, and that's not a bad thought. But you have to have them all be similar beats to call that. When you have a PVC, it's going to be bigger. So you have to have all your beats be basically the same morphology to consider pericardial effusion or pulsus alternans as well, that are both associated with effusion and tamponade. But this is a sinus rhythm. Good job. And there is, as Elijana said, by Gemini and Kamal. Yes. So let's walk through this one. Good job, everybody. So amazing job you guys all did. I'm super impressed. And if you're a student and that was a little over your head, that's okay. Just take again what you can from it and absorb. And you can always rewatch the recordings, which by the way, we'll be posting in the group when they are finished. In the meantime, speaking of recordings, I'm going to stop this one for now. And